Hey, good afternoon. This is Adam, and I want to do a quick recording on the Somali Comprehensive NCD program that we have been working on for the past 18 months with the partners from Allianz and Replexus. And Replexus helped us with our catastrophe bond that sits on blockchain. And more recently, we brought the UN in as a partner as part of the ECHO grant, which is what we're applying for now. So just some background on the environment in Somalia. Currently, over the past 7 years or so, the amount of money that's flown into Somalia for health through the official donor assistance channels has been fluctuating, but no more than 60 million a year on average. The amount of money is 40% of what the country actually needs. So in 2020, it was around $20 million. We have COVID, so obviously it went up to about 50 and change. But needless to say, it's dramatically underfunded. The WHO took a look at healthcare and the impact of productivity from an economic perspective. NCDs specifically have a huge impact on productivity. Essentially, 40% of productivity has been reduced because of NCDs, accounting for about $1.1 trillion. It's a big number. All of Africa's GDP is $1.7 trillion. In terms of how this impacts Somalia, it's around $19 billion, which isn't a big number, but it's 4 times larger than Somalia's GDP in 2020. SDG 3.4 is looking at reducing the amount of NCD prevalence by about a third by 2030. So that brings back another $300 and so billion, which puts a priority on this disease. For this program, we're going to be looking at Somaliland and Puntland up in the north in green. The Somali Red Crescent has roughly 70 fixed health clinics and 20 mobile clinics. Currently, the Red Cross movement members and other donors provide $3,900 a month to support the clinics. That doesn't account for medicine. It's only for operating costs. Essentially, a patient will go to a clinic. They'll be taken care of. It's basically first aid and maternal and child health. Anything else has been referred to hospitals. Those hospitals are in the urban centers, which makes it very difficult for people on the move to actually go there, especially because all of it is out of pocket. Approximately 50% of Somalia is on the move, of which nearly 4 million are displaced because of climate or conflict. Back in 2019, the Somali Red Crescent went and took a look at their health strategy. And on the left-hand side, these are some of the problems they identified. You can go through there in more detail, but just to highlight, one is essentially getting off donor funding. Another one is around data or a lack of data and monitoring and evaluation. Also, the unreliable supply chain, especially cold chain supplies, and not a lot of motivation for staff, the lack of training, and lack of funding. So what we're looking to do is to solve those problems, and insurance is a big part of that, or the process of processing claims, and then the data that goes alongside with that. This is just a slide you can take a closer look at when you have a moment. It just looks at some of the program that we're running at a high level, from the finance, the services, as well as kind of the impact. This is an important slide. It essentially walks you through the program itself. It has 2 horizons: the service layer on the bottom, which is all onshore, and then the top layer, which is the processing and payment layer, which is offshore. And the purpose for this is to have a fixed and variable, but also to allow the program to scale. The ambition for this program is not just Somalia, but it's actually to take it across Africa, the continent, and if we get it right, to take it global. The value of working with Allianz as one of the world's largest claims processing organizations is that they have consolidated claims in the Middle East, in Doha, and then in other parts of the world. So to take you through this quickly, 1A to 1B essentially pools the money from different donors into a trust fund, which is up here at the top. And the trust fund essentially is like a bank account. It sits in Guernsey, and it has an advisory board that releases capital per a budget. Money will drop from the trust fund into the individual clinics to actually upgrade them, and so there's some startup costs, and there's also variable medical costs that I'll go into. But once these clinics are up and running, we'll go ahead then open them up to various patients and clients to receive care. They go through an NCD screening process, and this is the point where we want to capture data. This is where the zero knowledge proof comes into play, where we can then qualify individuals and give them some kind of accreditation. And then that's very useful because, as you'll see in a moment, there's also community engagement. But as they get accredited, they get their accreditation, they get their service, a claim is produced, it goes into a team that's on the ground made up of Somali Red Crescent and also Danish Red Cross. And they create another data point or another entry point for information, and this is where not being able to know individuals by their name comes into is really important, because this is going to be a nationwide, and there's still different types of conflicts going on in different communities. So being anonymous is important. Once the claim is kind of cleaned up, if you will, it goes number 5. It goes up to Allianz. They validate it. They basically have a schedule of benefits, and they're clean. It's validated pretty much in real time, which is very unique for a health program. It's very unique for any program in Africa related to health. And that's important from the M&E side as well, the measure and evaluation. Once it's been approved, Allianz will then, out of their pocket, pay for the claim. It goes back down to the claims team, and there's an account there that is dual signed by the Danish Red Cross and Somali Red Crescent. Over a period of 12 months, the Allianz will eventually bill the trust fund, as you see 7 and 8. That's the billing process and the return. That 12-month float is really important, as I'll mention in a moment, but having 12 months to use the principle of the trust fund for other things, such as value guarantees, which is the concept around creating demand and then leveraging demand with the pharmaceutical companies to be able to get massive discounts. Once the claims are approved, the money goes into the claims team, then Allianz eventually reclaims the money, and then the trust fund drops the money back down to Allianz. Quickly here, this is sort of a kind of like a binomial tree of decisions as to how care is given, but what I want to capture your eye to is this back here at the end where we talk about caseworkers. The caseworkers are going to be on the ground working with community members, and then having that accreditation is going to be important to allow the refugees to be anonymous if they're on the move. They could be Yemenis refugees, they could be Ethiopian refugees. There are cultural issues, and obviously they'll be able to tell just from speaking, but we want to leave it at that. And that's where the zero knowledge proof also has a second layer. So for the point of entry at the clinics here when they're coming in, and then also when you start doing the community engagement. Quick numbers for you, just so you get an idea of the scale. In year 1, we're going to be doing just 4 clinics. Maybe we do more, but we'll keep it conservative. This is essentially 1 every quarter. The startup cost is around $50, $50,000, or 47,000 euros, and it just sort of streams across. And then second year, quarter 2, we'll be doing 2. So eventually, by the end of 2 years, we have 12 conservative numbers, but that's where we're at. It's about $600,000 per for those 12 clinics. Just for startup costs. Startup includes equipment, training, things of that nature. And then the variable cost, which would be the operating expense, it's about $35,000 a year. Currently, as I mentioned before, it's about $57,000, $58,000 a year. So this would be on top of that. That 57, 58 is what the base clinic is charging, or is what they receive from donors. We have additional expenses here. But what's also important, though, is if you look down here at the bottom, take a look at the numbers where it's startup cost per client. That's about $10. This is over a 2-year period, and ongoing costs per client. That's the variable cost. The operating expense about $7. So overall, the cost is $17 per head over a 2-year period. So it's pretty good value for money. This gets us into the innovative financing side. This grant calls for innovation. This is the whole purpose of why this grant is out there. And so we took our time to go through some detailed analysis. We looked at 40 different types of innovative health financing mechanisms over the last 20 years. And we pooled some of the better things and some of the things that didn't quite work. And one of the nuances that we noticed was that there wasn't a single mechanism that applied insurance. And that's interesting because the value that insurance can bring if done right. And I think in the context of this program, we're not thinking about insurance as the product, but thinking about insurance as the system, and that there's a difference there. But what we're trying to capture are 3 different streams. One is result-based financing, another is catalytic funding, and then impact investing. And in this next slide, I'll show you how that looks. So we start out with a catalytic fund. This catalytic fund is our trust fund, and this is where the funding will pour into. This is the beginning of the flow chart you saw earlier. There are 2 streams of financing that comes out of this. The first one would be for health programming, and that's essentially cash into the program so that we can stand them up. And then the second would be leverage. Leverage is important, and the relationship with Allianz to have 12 months of float is important for this bit, because that allows us to keep the money in the trust fund as long as possible and to do things like volume guarantees, insurance guarantees, and that having that cash there allows Allianz to have trust and faith that they'll eventually get paid. And so if we go back up to the health programming side, this essentially from the catalytic fund programming, pushing the money into there will generate outcomes, right? And the reason why we look at this as an important layer is because results-based financing is you do something, you get paid, right? So cash on delivery, and essentially by being able to pay for claims that we have validated, i.e. Allianz has gone through the process of validating them in real time. We know they're real, they're relevant, we have a good value for money, and then those outcomes that are generated from that process drop into sort of like a menu. So you go to a restaurant, you can say, hey, I'll have 7 tacos and 5 baozi and 6 falafel. It's a continental menu, and you know what you're gonna get because you can see the price. And that's the same concept here. We can deliver certain outcomes, certain health outcomes at a certain price point, and we can have investors come in and buy those. They don't need to invest in an entire program. They can buy the results. So that would be kind of the second bucket of financing. As the program matures, it goes from standing up the programs, from now delivering high quality long-term health outcomes. We can then get private sector involved, and they can start looking at the results side. And this is where the blended finance comes in, where we could have concessionary loans, guarantees, things of that nature. But this idea around health tech enterprises, claims processing. So in country, you could create a Somali like claims processing that could actually be for the Horn of Africa. You could do health clinics. We could bundle up the entire Red Cross health clinics, put them into securitized asset and sell them off, and professionalize it. And you could do this across Africa. It wouldn't just be for Somalia. You could imagine Somalia being the starting point for 500, 600, 700 clinic unit network, all backstopped by this kind of back end with Allianz and the Red Cross. That essentially brings us there. To put this in like a really high level, we have something called loop financing. It looks a little bit like a butterfly, but what the idea is that you have different legs of financing, and the different legs of financing allow for continuous operation. You're not relying on a single source, you're not relying on a single relationship, but you're relying on the fact that they're all interconnected in some way, and they're interconnected by the trust fund. And so they flow back into the trust fund. For example, with the catalytic funding, you have your trust fund, the money which is pouring in from donors, that scoops into the trust fund. That's just you can take the principal of the trust fund, you can invest that in capital markets, that can flow back into the trust fund. The results-based financing, we're developing outcomes. Imagine you're creating carbon credits for planting trees. It's the same concept here. You're creating health outcomes that could be sold. And then the other is impact investing, right? That's a longer term, but eventually those networks will be developed and they could be monetized, collateralized, securitized, and then created like this very professional network. That's sort of the approach from an innovative financing perspective. And then here's a group of the individuals that we're working with. On this side here, Sanlam is Allianz now is Africa's largest insurance network. That just happened recently. So thanks very much. Have a good day.